Next up, we have Danny Vadas. He's the CEO of Victoria's peak consumer health advocacy body, the Health Issues Centre. And over his career, he's been a strong advocate for consumers on health, environment, and civil rights reform at the policy and practical levels. Over the last 3 years, Danny has participated in an advisory role on 3 major end-of-life initiatives introduced by the Victorian government. Those are the Medical Treatment Planning and Decisions Act, the Palliative Care Framework, and the Voluntary Assisted Dying Act. So Danny will begin by setting the scene on social connection from the perspective of the community members, and then he'll share with us some of the Health Issue Centre's community initiatives. Welcome to Danny.
Thank you. Good morning, everybody. Hard act to follow, that one, but I'll do my best. So I've titled this When I Think About My Future, because I guess we've been on a journey in the last few years looking at how older Australians see their future. And it's been in the context of having a look at the swathe of end-of-life initiatives that the Victorian government's announced in the last 2 years, the Palliative Care Framework, the Voluntary Assisted Dying Act, and of course the Advanced Care Planning Act, or the Medical Treatment and Decisions Act. And the impact that's having on people, or the impact that's not having on people. I'll come to that in a minute, but initially I should just do a bit of a word from my sponsors, tell you about who we are. So for those of you who've never heard of the Health Issues Centre, we've actually been around for 30 years, so we're a well-kept secret if you haven't heard about us. And our primary role is to work within the health sector, to work with all the stakeholders in the health sector, but in particular to work with consumers. And the traditional model we've used in that sense has been to provide recruitment services, so finding consumers who want to participate in formal engagement processes, advisory committees, more recently co-design committees. We provide training, we provide resources, we provide mentoring, but as we've evolved the process and trained more consumers, we've been struck by the fundamental limitations, I guess, of trying to drive change through that sort of model. That being that no matter how many consumers you recruit, there's only so many governance committees, there's only so many seats at the table. And what happens to everybody else? So our view is that if you want participation, consumer participation, to be a universal possibility rather than an elite sport, we have to rethink the opportunities that we create for people to participate. And I guess that's partly, I suppose, reflected. I pinched this diagram from Bolton, Clarke, because I thought this is good. Always happy to steal something that's useful. This gives a clue to what the problem is, I guess. If we really want equitable participation in care, then how do you engage with those people? In this instance, we talk about diversity. For us, we're more inclined to talk about social determinants. Not quite the same thing. Many of these are social determinants. Many of these are factors which actually stand as barriers to people having equitable access to the health system. And one of the things we've come to realise is they're also barriers to participation. So unless you keep wanting to talk to fairly homogeneous rooms like this, middle-aged, middle class, largely white, women, and by no means is that a criticism, it's a recognition of the limitations of who we actually engage with. You need to think of other processes. So we sat down a couple of years ago and said, all right, if we were starting with a blank piece of paper, if we said everything we've done for the last 30 years may not be quite right, let's think again. We asked ourselves, what would a really good gold standard participation process look like? And the definition we adopted is this: a true participatory model embraces diversity, the vulnerable, and the hard to reach, so that they too may influence outcomes, which I have to admit is a very worthy ambition. The next challenge, of course, is, well, how do you make that happen? So we haven't quite entirely solved the problem, but we've gone a long way towards it. And one of the things we've done, and I want to talk a little bit about this within the context of today's subject, we've developed what we call a model of social listening. So social listening is actually a fancy name for having a conversation. We talk about it as the art of finding out what you're not looking for through conversation. It's the sort of the unknown unknowns. And we use a number of tools in social listening. Primarily, and lots of raised eyebrows when I say this, we use social media. For all the formal researchers in the room, sorry, but it actually works really well. Partly because it's ubiquitous. I mean, between the social media platforms, particularly something like Facebook, which in Australia has in excess of 18 million individual accounts, and the smartphone, you have the most ubiquitous, powerful communications tools ever invented. And for those who are rushing to say, oh, what about older people? There are 1.6 million Facebook accounts held by people over the age of 60 in Australia, and it's the fastest growing cohort among Facebook users. Why? Because that's how we track our children and our grandchildren when they're on holidays in Nepal. That's how we stalk them, which is also why the only cohort that's decreasing in terms of representation. You got it. So we use social media, but not just social media. We use street interviews. So people who say, oh, it's too hard to reach, those diverse communities and the people who are sort of not highly health literate, and it's too hard. No, it's not. You basically take a camera, which these days is an iPhone, and you go down to Victoria Market and you ask the first 30 people who walk past. Guarantee you get a really good cross-section of diversity. We use social interceptions. And it's a bit, I suppose, in parallel to what Barry was talking about. We don't use focus groups. We don't use formal consultations in situations like this. Because we think if you want to have meaningful conversations with people, you go to their comfort zones. You don't drag them into yours. So, for instance, and I'll talk a little bit more about this, work we've done in East Gippsland on the ageing population and the fact that they appear to be underrepresented in medical appointments, counterintuitively. What we did, rather than just calling for a public forum, because if you want to examine isolation and loneliness, it doesn't really make sense to ask people to come to a public forum, right? So what we did was identify the places that we knew we could find them. So it was the local farmers market, church services, local pharmacy where they're picking up their scripts. Really important one was the local pub that did half-price schnitzels on Tuesday. So it's about talking to people, engaging with people where they feel comfortable and familiar. So I want to give you a couple of examples of how we've done this and what we've learned. And I'll say this model's been far more powerful than we thought it was going to be. In fact, every time we go out and have a conversation, we come back and think, we got it wrong. This doesn't reconcile with our preconceived notions. It's one of the reasons we've stopped doing formal surveys. Formal surveys are really, really good at reinforcing your own prejudices, so you can go, aha, I knew that's what we were going to get. What we do is consumer-driven surveys, so we actually allow the conversation to design a survey. But I'll give you an example. I was talking about our work in advanced care planning, which we started 3 or 4 years ago. And our commission from the Department of Health and Human Services was to develop more consumer resources to encourage conversations around advanced care planning. And what we found from our desk research, you always start with desk research, was there was a stackload of resources out there. So the problem wasn't a lack of information, it was a lack of engagement with the information, and we wanted to know why. So what we do when we have a question like that, when we're faced with an existentialist question, is we actually go out and talk to people. So as an example of what we do in terms of, what have I done? Did I break it? Oh. We sent our camera crew out to Victoria Market and we simply asked older Australians, tell us about what your future looks like. And this is what, hopefully, they told us. More?
How do you imagine your life when you reach retirement?
Got to have a bit of money behind you, or if you haven't, you're going to struggle.
Working till the end.
I've used to be on a disability pension, and they cut me on the dole. I was on a disability pension for 20 years, so I got no super at all.
Well, I guess because I am retired now, and I've had to look at my financial situation.
I have my insurance and that's it. Yeah, just enjoy every day as it comes.
Yes, think about retirement quite often, getting closer to retiring age. Not really sure what it looks like. Probably looking at what to do rather than working full time, what sort of things I can do, whether it involves travel or moving from where I live now to a more easy lifestyle.
Well, I'm pretty mobile, and so I can get around. I have my health, which is really great when you retire.
Oh yeah, just cruising. We like cruising, so I want to do a lot of cruises. But
Now I just basically sit and read. We go on a few trips around the place.
Have you thought about things like, I don't know, when you're maybe not quite able to take care of yourself?
Yes, that's when I go into a nursing home.
Oh, you mean financial plans?
No.
Oh, right.
If you're a bit ill and maybe can't make good decisions for yourself or anything like that, have you thought about those sort of
No, I haven't got anything in place for that. Good point, though. Yes.
Yeah, geez, that'd hurt if I lost my mobility. Yeah, no, to be honest with you, I haven't really thought about that.
I don't look that far ahead. I just take it fairly short term.
Just waiting for that thing to happen, really. Which bit of a no, I don't know about that one. Tell you on the truth.
Not really, no. I'd rather work on what I've got. Yeah.
We will have spoken to that and probably spoken to our daughter about it if we do get into a position where we can't make decisions for ourselves, whether we'd like to end our lives or, euthanasia, those sort of things. We'll have to talk about that, and it's hard to know until you're in that position what you would really do. It's easy to say it until it hits you, and then, well, okay, maybe I don't want to die, maybe I do. But we talk to our daughter about that and what our wishes would be.
It could be as time comes, but it's got to wait until it gets here.
So I do think about it, but I don't think I get that seriously into it. My husband's still with me, so I suppose we're dependent on each other, so there's the help. However, if anything happened, actually I do think about it, but I haven't. No, what a good thought. You've got me thinking now.
I am concerned about those latter years in my 80s. If I get to my 80s, that's when everything starts to fall off and fall apart.
Well, my father was 85 when he passed away, and he was healthy. He was still digging gardens right up to his 80s, so I'm hoping I'm like him. So that's what I'm sort of counting on.
yeah, well, at the moment I've got stomach cancer, so I just want to survive for every 6 months. So I said I was going to die 6 months ago, but I'm still alive. So I'm just hanging in there.
That's a really tricky question, because I think most of us don't want to be a burden or be in a situation where we're living like a vegetable and just being kept on, sort of with no real quality of life. I think that's a really big issue. But I haven't really gone down in detail that path.
If I can't get around under my own steam, it's not a poor effort, but I'd like not to be a burden.
Have you had a chat to your wife about these things?
No, not really. No, we haven't really.
Well, we've got 4 sons, very nice boys, and they've got lovely wives, and so we're very happy families.
Okay. And you reckon they might take care of you later on in life?
Oh yeah, I'm sure they will.
Okay. Have you discussed it with them?
No?
We can drop it on them.
Oops. Back to where we were. Okay. So that's what happens when you talk to ordinary people. And it's really interesting, it's the strategies people adopt to deal with the question of impending death. So you've got your pragmatists who say, well, there's nothing I can do about it, may as well enjoy my life while I can. There's the fatalists, like, oh, well, no point worrying about the future if it's inevitable. There's the optimists, oh, I'm going to be like my dad, he worked till he was 85 and dropped dead in the guard, so I'll do that. Then you've got your denialists, oh, no, we don't think about those things. Yeah. And then, of course, you've got your complete delusionists, my kids will look after me. So this caused us to ask ourselves, what's so scary about this? Because it's not like, as a society, we don't talk about death. I mean, people are quite comfortable about estate planning, even planning their own funerals, to the extent of choosing the music, deciding who the guest list is, and more importantly, who's not on the guest list. But when you look at that conversation there, when we did press people to talk about their future plans, they only talked about financial planning, my superannuation, my insurance. When you said to them, what about your health planning? They go, what? And when you say, what happens if you lose your sight, if you lose your independence? It's, oh, I've never thought about that. So it's like, oh, I'm going to retire, get a caravan, go touring, go cruising, spend more time with the kids, spend more time in the garden, and then drop dead. And nothing in between. So we thought, okay, well, this is a really interesting starting point. Clearly there is something that prohibits people or disinclines people from wanting to focus on that part of their life. So we've conducted a couple of interesting projects using social media, and one of them, which followed on from this, was simply a conversation with people where we were asked, what worries you about ageing? And this just gives you an idea of the power of social media. So over the space of 4 weeks, we engaged with 72,000 people. We got about 49,000 reactions. Now that can be a like or a share or whatever. But we had, as you can see, over close to 15,000 comments. So what we do is we use a process called keyword search and sentiment analysis. So we look at the main themes of the conversation. We don't mediate the conversation. We don't direct it, because if you do that, then you don't get the wonderful surprises. But what we do is we look at the keywords, we look at the common sentiments, and we use those to frame the questions. So out of that question, did a search, and the terms that came up quite frequently were burden and stubbornness. And so you go back and you ask the obvious question, why are you so stubborn? And people would say things like, and these are just typical responses, not stubborn, just that we don't want to go yet. Or just trying to be independent as long as possible so that I'm not a nuisance to my family. Giving up is the beginning of the end. Or as the last one, very poignant, as I get older, I realise getting old is not for sissies. And losing any tiny bit of independence is heart-wrenching. Not being able to drive at night, not getting the lids off bottles, even not being able to clean parts of your own house. So that gave us some clues. So it's not necessarily dramatic decline that causes the problems. It's the small incremental decline. So a little while later, how am I going for time, by the way? All right? Okay. I talk very fast when I get to the last 3 minutes. So a little while later, we were approached, as I said, by Gippsland Primary Health Network, and they wanted to look at the question as why older people seem to be underrepresented in clinical appointments. And they'd previously done their own research, very extensive research, had over 1,000 respondents. But as you do in research, you give people tick boxes and you say, what would be the thing that would make the greatest difference to your health? And the answers, of course, they got were more exercise and better nutrition. And you go, okay, now what do you do? So we suggested to them we try our approach, that we have an open-ended conversation. We used a combination of tools. We used social media. We went to the local pub when they were doing half-price schnitzels. We asked for trusted informants, their opinions. That's people who have a lot of interaction with older people. Hairdressers, managers of local shopping centres. And what we found, we also do run surveys just to get the conversation started. So when we asked the question, or the provocation we posed, we call it a provocation because the intention is to get people to respond and start a conversation, was, it's not easy growing old, tell us what's difficult about it. And not unexpectedly what you got was people talking about losing physical capacity, losing mental capacity, becoming a burden. Most importantly, or the number one concern was losing my independence. We all know that. But what happens when you start digging into the conversation is the nuances come out and you realise, okay, it's not quite what I thought it was. So we asked them about dealing with decline. And these are the sort of responses we got. There were people who were concerned about physical decline. Tire more easily, can't do as much as previously. Maintaining fitness is an issue. Frustrating for me not being able to walk distances and do simple things like walk the dog. And then people would talk about cognitive decline, trying to remember where I parked the car at the supermarket. My memory is not as good as it used to be. I deal with this by making notes. And then they'd talk about emotional social decline, the heart-aching loss as friends die, looking after ageing siblings. One of the things we keep discovering, or that we realise that we sort of knew but didn't really know, was the number of people, older people, who are looking after older people. People in their 60s and 70s looking after parents in their 90s. That's a new phenomenon. That didn't happen 50 years ago. So what does that mean if you're having to deal with your own ageing process, but you're completely preoccupied or distracted by looking after somebody else's ageing issues? I suffer increasingly from anxiety caused by the knowledge that my future is shrinking. Okay, so this then led to a couple more interesting questions, and we started getting some insight that things were a little bit different to what we thought they were. One of the things that kept coming up were issues of identity, not just independence, but identity. So people saying, maintaining my identity as an individual, not being put into a box as an elderly citizen. People not taking older people seriously. Hate getting old because people treat you like you don't know what you're talking about, like you're getting senile. Being made to feel unnecessary or irrelevant by younger persons. Not being listened to, being dismissed. Being ignored or treated as a simpleton. The last one I thought was really cute. I no longer feel respected and I no longer feel a sense of belonging. I'm never invited to fun activities. So what began to emerge was it's not just about a loss of independence caused by physical and cognitive decline. It's a loss of identity. It's like, if I can't do these things anymore, if I can't take the lid off a jam jar, if I can't climb the ladder to clean the roof, who am I? We also had a look at how do we, as health professionals and aged care workers, fit in with this. And one of the disturbing things we found was that too often we're exacerbating the circumstance. So doctors that don't listen and rush you out the door, or when you do finally get to see a GP and you take a big long list of things because you'd have a big long list and they say, sorry, you can only do one Medicare item at a time. So what emerged out of that, and I'm doing this in a very condensed way, was a concept that we hypothesise, where we talk about the spiral of decline and withdrawal. And we see what happens is that with incremental physical and cognitive decline, as those little things take root, there's an erosion of self-esteem. People think poorly of themselves. They actually blame themselves because they can't walk the dog or they can't take the lid off the jam jar. That then causes a loss of identity, which in itself leads to social and clinical withdrawal, and we know social and clinical withdrawal leads to isolation, depression, further health decline, etc., etc. The interesting thing here is acknowledging that people may be contributors to their own isolation and withdrawal, that it's a conscious decision because everyday interactions become painful. And so what do? You withdraw. Is it a coincidence that older people, when you talk to them about their activities, they list gardening, reading, painting? They're isolated activities. So we think there's more work that needs to be done in this space, and we need to stop equating isolation and loneliness as two sides of a coin. And we think that part of the problem is not just about lack of social contact, but it's lack of social relevance. So, one of the comments before was, I'm sick of being invisible. We had people talking to us about their issues around invisibility, and like, I'll be in a shop and everybody else gets served except for me. Or people talking about the fact that, I don't know if I'm imagining it, but I would swear that I'm bumped into in the street more often than I used to be because people don't see me there. Or because I move more slowly, whichever. So what do you do about invisibility? Well, we've done a couple of things. In response to the fact that this is a subject that people don't want to talk to. Now, one of the issues we have as health service people is we rely a lot on evidence-based information, right? So we think if people aren't listening or if they're not changing behaviour, give them the evidence. And if they don't respond to the evidence, give them more evidence. And if they still don't respond, hit them over the head with the evidence. We actually think we need to develop more clever strategic processes for engaging people. So we came up with a performance arts event, some of you may have seen it, called Unspoken What Will Become of Me. And the intention, because if you really want people to engage with something that's uncomfortable, do it through art, do it in a non-confronting way. So we created this show. It's been touring over the last 18 months throughout Victoria, started off at State Library in Melbourne, and has toured through most regions in Victoria, and we're still hoping to get sufficient interest to keep it touring for another year. And it consists of a number of installations. And some performances. So the installations include things like this. You can't really tell from this photo, it's a great photo, but that's a sculpture about 4 metres high made of walking frames. And it's called Frames of Reference. And so what we do is we mediate a discussion around that and say, well, what does this signify, these walking frames? Is this an admission of loss of independence? Or is this a mechanism for extending independence? The key part of the show, though, is a performance piece by a couple of wonderful performers called Born in a Taxi, who do a game show called This Could Be the Rest of Your Life, where we play out a number of scenarios in a somewhat humorous, somewhat poignant way. And it's based on what we've identified in terms of identity loss as the 7 deadly signs. So there are things that happen over and over again in people's lives that we need to pay more attention as to how we deal with them as a society. For instance, losing licence. I mean driver's licence. Okay, so there is no mechanism in Victoria at the moment for dealing with this in a rational, sensitive way. So if you believe that an older person in the family is no longer competent to drive, you can either demand the keys, you can cop out and go to the local GP and ask them to tell them to hand in their keys, or you can actually dob them into, the Victorian, who will then impose a medical test. 80 people a week in Victoria lose their licence by that mechanism. So at a time when people are really concerned about their loss of capacity and their loss of identity, we actually deal with that in a fairly insensitive way. Now, I remember my dear mother, who died a year and a half ago at the age of 97, sorry. When she was 87, I convinced her to give up her licence. It took me 3 years. She only ever used the car to go to Coles, which was 500 metres down the road. It wasn't about mobility, it was about independence, it was about identity. It was my mother also that taught me this when visiting her in a residential aged care facility, and at the age of 96 she still insisted on making her own bed every day, hospital corners, even though she only had one good arm. And I said, Mum, you don't need to do this, there are people here who are paid to do this. And she said, no, I have to. And I said, why? Don't you think they can do hospital corners here? And she said, no. It's because that's who I am. And I realised when she refused to use a walker, even though she was vulnerable for falls, that this was a woman who was struggling to maintain some sense of self. It also happens, I talked about the 7 deadly signs, so there's losing a driver's licence, there's that other conversation, Dad, it's time you stop climbing the ladder to clean the gutters out, because 90% of ladder falls are men over the age of 60. It's about downsizing. It's like, Mum, Dad, don't think you need a 2-storey house when there's only the 2 of you living in it and you can't get up the stairs. It's about home help. Now, how crazy is this, right? If somebody said to me, how would you like to have a gardener come around 3 times a week, someone come and cook your meals and someone clean your house, I go, yeah. Say that to someone who's 80 and they go, oh, no, don't need that, don't need that. So there's this whole issue, and I think this is where we perhaps need to refocus a little. If you're not who you were, if you no longer are the person who cleans the gutters, who cooks Christmas dinner for 25 people, who climbs the ladder to clean the gutters, who are you? Who are you? So we think tackling social isolation, apart from looking at independence, needs to look at relevance. And in that regard, we are hoping to launch, and I'd hope to be able to report it today, but the pilot got derailed. We've developed the concept of a program called Common Threads, and the idea there is to help people reinvent their identity. If you can't be the person you were for the first 60 years of your life, that doesn't mean you should be nothing. It just means we need to rethink it again. And you know what? You can have an identity even if you aren't independent. And if you don't have complete cognitive, physical capabilities, you just need a sense of self-worth. One of the things we started doing when we were touring the show around Victoria is to look for happy people, look for happy older people and ask them, you know, what's keeping you happy? What is it that you do now that you're retired? And we had some pretty amazing stories. I remember one man down at Foster telling me, well, I've quarantined a wall of the house internally and I'm going to create a mural of the history of the world on it. Great project. So there were a lot of people who seemed to be happier, and they were the people who had actually found some probably arbitrary project that would give them a sense of purpose and relevance. One of the things, there's a couple of things that we found happening over and over again. We found a lot of older people who had become self-appointed guardians of the family album. So had learnt how to manipulate digital photography, collect photos from grandkids and aunts and uncles, and they had become the guardians. Similarly, a lot of old people who had got into genealogy were tracking right. We see these as attempts for retaining a sense of relevance and purpose and maintaining some sort of status either within the family or socially. I got to the end within 3 minutes. So our intention is to roll out that program. We're negotiating with a couple of potential collaborators to see if we can do this. We see it being both an online project and a face-to-face project. So if anyone sees that this might be of interest, happy to have a chat afterwards, but thank you for your time.
Thank you, Danny. I think we have time for a few questions before our panel discussion.
Thank you very much, Danny. There's $600 million of unspent packaged care funds across Australia. What are home care providers not doing in regards to an understanding about loss of identity as they try and come in with a whole range of services and then say, oh, we can't sell anything to these people, they won't do anything. Like, what's missing? Because how have we got $600 million of unmet need across Australia?
I think what we often confuse is self-empowerment with kindness. So we focus on trying to be kind, make cups of tea, take people off on picnics to the top of Mount Macedon when they don't even want to go. I mean, one of our fears is that, you know, now that loneliness and isolation has been identified as a important social issue, that hundreds of millions of dollars are going to be spent on community buses dragging people to places they've never even thought of going. We think we need to focus differently. We need to listen to what people are saying, which is all we try to do. You know, I'm not here as a researcher or as an academic expert. I'm here basically just channeling what we've been told by hundreds and hundreds and thousands of people. So it's no harder than listening very carefully, drawing out the insights from what you hear and then repurposing the project. But I'd love to get my hands on some of that $600 million.